Hello, my name is Kshef Kamran, and I'm a third-year biological sciences student at the University of Calgary. I conducted clinical neuroscience research exploring the efficacy of repetitive transcranial magnetic stimulation as a potential treatment for persistent post-concussion symptoms with specific focus on the quality of life. Approximately 450,000 Canadians acquire mild traumatic brain injuries or concussions a year. Also, of those who sustain a mild traumatic brain injury, about 18 to 31% experience persistent post-concussion symptoms lasting beyond 3 months. Symptoms can include but are not limited to headache, dizziness, fatigue, and memory difficulty. These symptoms can debilitate an individual's well-being and impede on quality of life. In addition to that, persistent post-concussion symptoms has very few evidence-based treatment options. However, a potential treatment that has been gaining attraction due to its promise in overlapping symptoms such as depression and anxiety is repetitive transcranial magnetic stimulation, or RTMS. RTMS is a non-invasive neuromodulation treatment that transmits a magnetic field to the underlying cortex of the brain, and this treatment has been Health Canada approved for obsessive compulsive disorder as well as major depressive disorder. The primary objective that I looked at was if RTMS improved the quality of life after brain injury scores compared to sham RTMS in adult patients with PPCS. In this double-blinded randomized control trial, we had recruited 65 adult patients from Calgary outpatient brain injury clinics. Also, the Colibri questionnaire was assessed at the pre-treatment and then at the post-treatment 1 month and 3 month follow-ups. As of July 2023, we had recruited 65 participants, and this is the breakdown from pre-treatment to post-treatment to 1 month and the 3 month follow-ups. And as you can see, there are minimal dropouts, which shows a very high retention to our study. To be included within our study, the participants had to have had an MTBI within 3 months to 5 years, as well as a PPCS diagnosis, and they had to have kept their treatment regimen consistent. Our exclusionary criteria consisted of the following: not having a history of seizures, not having a psychiatric disorder diagnosis, and not having any metal devices within 10 centimeters of our treatment location. Our RTMS protocol begins with conducting the resting motor threshold, which involves single pulse taps to the motor cortex that are strong enough to elicit a muscle twitch. Based on that, we can determine how strong our treatment intensity needs to be. Then, the participants are randomized to the active or sham RTMS groups, and in terms of the coil, they look exactly the same. However, the sham does not receive an effective amount of the stimulation. Then, all of the participants receive 20 sessions with their respective RTMS or sham treatment at high frequency with 10 hertz, 10 trains, 60 pulses per train with a 45-second intertrain interval between each train to the left dorsolateral prefrontal cortex. The left DLPFC is hubbed to the frontal lobe, which is responsible for executive and emotional regulations, which is often impaired in individuals who acquire mild traumatic brain injuries. Then I evaluated the difference between the Colibri scores from pre-treatment to each subsequent follow-up and determined the difference between those two groups, active and sham. In this figure, from pre-treatment to each subsequent follow-up, there was a significant effective time as shown by the post-hoc comparison. However, there was no significant difference between the two interventions, sham and active. This is the largest study to date that looks at RTMS as a potential treatment for PPCS patients, and the first to explore quality of life as a primary outcome measure following RTMS in adults with PPCS. For the sample as a whole, the quality of life improved up to the 3 month post-treatment time point. The quality of life improved for both the active and sham RTMS groups, and this was likely due to a limitation of our sample size, as this is an ongoing study and the data I analyzed was up until July 2023, so it would be interesting to explore how the data compares in the future in order to develop clinical pathways for Calgary community members that have experienced brain injuries and to determine potential treatments. Finally, I would like to thank everyone in the BNR lab for their help and support, as well as my funding sources. Thank you so much for listening.